This is Stephen Holloway. We're going to be talking now about testing for coronary artery disease, heart disease. We'll also talk a little bit about treatment as we talk about PCI. But this really looking at some of the different testing that you may be helping your patient get ready for to diagnose their coronary artery disease or the extent of their coronary artery disease. Or you may be sending your patient in for a cardiac cath for a stent or for arthrectomy. So this will cover all of that as we look at that. We're going to start out talking about stress testing or exercise electrocardiography. There's two different types of stress testing, and you may hear it called a stress test, a GXT, which GXT stands for graded exercise test. But basically the whole premise is to put the heart under stress to see if there's ischemia. These are done either by having the patient walk on a treadmill, ride a bicycle, or by chemically stressing the heart. When we look at taking care of these patients for this, really what we're trying to do is determine, is there a problem that's going on, and if there is, then we'll need to determine what to do for these patients. Typically, these patients pre-procedure, and most of this is done as an outpatient basis. It can be done inpatient if you have a patient that's in the hospital already. One of the things we want to teach our patients is no smoking, no alcohol or caffeinated beverages the day of the test. Really, we would prefer them not to have any caffeinated beverages 24 hours prior to the test, and no smoking 24 hours prior to the test. But most of us know that our smokers are going to have a difficult time going for that. If the GXT or the exercise stress test is sometime in the afternoon, they can have a light meal 2 hours prior to the test. We don't want these folks eating a big heavy meal and then getting on a treadmill or being stressed using some of the chemicals. Have seen that happen. Unfortunately, patients didn't follow. Large amount of vomitus coming up as we stress these patients. We want to make sure that we tell our patients to hold any beta blockers. Now, you can't just tell your patient to hold beta blockers. You need to look at their list of medications and make sure you understand which ones and tell them, stop this one, stop this one, stop this one, okay? You want to have beta blockers, calcium channel blockers, and if they're on digoxin, you want to stop the digoxin as well. We want to make sure that patient is instructed to wear comfortable, loose-fitting clothing and very comfortable shoes. Tennis shoes if possible when they come, because basically if they're able to do the walking treadmill, they may be on that treadmill up to 20 minutes doing that. Now, because this does involve typically risks, patients do have to sign a permit before they begin this procedure. Now, during the process, and a lot of times there are RNs in there managing these patients and assisting with these patients. This RN will be basically ensuring the emergency equipment is there and ready to work. The RN will attach the patient to the EKG and the blood pressure machine, and they will be watching the EKG as well. Now, there will be a healthcare provider in there, whether it be a physician or an advanced practice nurse. They will be there doing that, but the nurse will also be monitoring the EKG and blood pressure. And the nurse is going to be responsible for talking to the patient about the use of the equipment, talking to them about reporting chest pain, those type of things. Now, once the patient's put on the treadmill, they're started at a slow pace, and the pace is gradually picked up, and the incline is picked up a little bit. The patient will exercise until a predetermined heart rate is reached, or signs and symptoms of cardiac ischemia shows up, which would be things such as a significant ST depression or T-wave inversion, or they have chest pain. It would be stopped at that point in time. The other thing that will stop it, if they meet the full 20-minute protocol. Now, most of the time now, they're actually doing a radiographic type thing where the patients are injected with a medication prior to it. One of the things that you'll see is called a LexiScan or different type things. Those are more chemical, but basically the patients are given a radiopaque type dye, isotope, and then after the heart has been stressed, you go back in and they run the thing over you, looking to see if they can see any hot spots or areas that are increased uptake with that. We'll talk a little bit about those a little bit more as we go along. It's not hard, not difficult to do for these patients, but they need to be aware of what's going on. Once the patient has completed the exam post-procedure, we need to make sure we're monitoring them until the heart rate and blood pressure return to baseline. If they've had chest pain, of course, then at that point it's a different process. Typically, they will then either been sent to the emergency room, or if they're in the hospital, different steps will be taken at that point in time. One of the things, once these patients are sent home, we want to advise them not to take a hot shower for 1 to 2 hours after the test. And this is to prevent them from having hypotension. So we need to make sure that we're teaching those patients those. Now, the chemical stress test uses medications to actually put the heart under stress. The one that we're seeing most right now is the LexiScan, and it's the one that several of my students got to see this semester at the Huntsville Hospital. Others can use dipyramidol, Persantine, Dobuterex or dobutamine, or the LexiScan, I can't say that one, Regadnosone, to actually put the heart under stress. These patients, again, will be given the radioisotope when they start this test, and then they will go back later in the day. They'll do the stress test, see how it looks, and then they'll go back later in the afternoon for the scan to see. But these medications basically cause vasodilatation and basically stimulate the heart just like exercise will. So you're going to get workload on the heart, vasodilatation of the coronary arteries, so that you can see how well the coronary arteries are perfusing. Some people say it's very makes them feel very sick. My wife has had these, and it really just makes her feel very sick at her stomach. These medications do, as she does these stress tests, but that goes away fairly quickly for these patients. Now, pre-procedure, very much like the other one, no smoking, no alcohol or caffeinated beverages on the day of the test. These patients do need to be NPO 4 hours prior to the injection of the medication. Again, you do have to have a permit signed and an IV established on these patients. You want to advise these patients that these medications may cause flushing, headache, dyspnea, chest tightness for a few hours after the medication is given. So advise them that. Of course, again, we're going to be monitoring the EKG and blood pressure. And post-procedure wise, we're watching for the return of the vital signs to the baseline for these patients. Again, can be done inpatient or outpatient for these patients. The other thing that we may see is nuclear testing. And again, these are actually sometimes done along with the stress test. The technetium scan, basically that medication or that isotope is given, and it accumulates in damaged myocardial tissue, and it will show up as hot spots. This is only for an acute MI, but doesn't show old MI type areas. Now, the thallium scan's not absorbed in any damaged myocardial tissue and will show up as cold spots on these patients. This just kind of shows you just a little bit what it looks like. Technetium-99 pyrophosphate is considered hot spot imaging. Again, that's given to the patients, and damaged areas are going to show up kind of a bright orange on the bright red to orange on the imaging. With the thallium scan, again, it's called cold spot imaging. Again, all you're going to be worried about with these patients is getting them in and out and taking care of them during the scan. You're not going to be reading the scans, looking at those. Just understand that these patients may have questions, and you'll be supporting them through this process. The PET scan, the cardiac positronic emission tomography, basically is looking more at the cardiac arteries. Again, this is what you're seeing more as having these LexiScans, those type of things. The radioisotopes are admitted to the patient by IV injection or inhalation. Most of the time it's been IV. And one isotope targets the blood, one targets the glucose. And then basically these patients then are put into the PET scanner, and you're looking for normal blood flow and glucose metabolism, which indicates good coronary perfusion. If you've got decreased blood flow with increased glucose metabolism, that indicates ischemia. If you've got decreased blood flow with decreased glucose metabolism, that's an area of necrosis and scarred heart tissue. So very good test. Again, used a lot of times with the stress testing to really get a good view of the heart. Another one that's being used some is called the coronary computed tomography, or basically CTA. Basically, it's using a CT scan to look at the coronary arteries. using this a lot of times as a non-invasive type screening process, looking at the coronary arteries. Not as good yet as a cardiac catheterization for looking at the coronary arteries, but again, a non-invasive type thing that we can use for patients. Pre-procedure, these patients have to avoid caffeine. They have to avoid caffeine. These patients are going to be given beta blockers, and these beta blockers are given to slow the heart rate down. The heart rate needs to be down close to 50 to really get a good view of the coronary arteries. Of course, an IV is going to be established. The beta blockers, typically, what I have seen, have been given by mouth instead of IV. If someone's coming in from an outpatient, they can be given IV to slow the heart rate down. During the procedure, these patients are given that radiopaque solution again, and a CT scan of the heart is taken. Then they're looking for any streaking. They're looking for those atherosclerotic patches that are in there, looking for any kind of occlusions that may be going on. Post-procedure, again, nursing-wise, all we're going to be doing is monitoring that heart rate for those patients and monitoring their blood pressure. Of course, the big concern is with these patients, that beta blocker, that slow heart rate, and that problem with the blood pressure. So these patients may need to be advised to take it easy until that gets out of the system, move slowly to take care of those. The gold standard in looking at the coronary arteries and really for treatment of most of the MI type issues is the percutaneous cardiac intervention. Most people will call it a cardiac cath. Okay, the cardiac cath really is just looking at the vessels. The other things such as the PTCA, the angioplasty, and the stent placement and arthrectomy are actually treatments for those. Most of the time, though, when we go in for the cardiac cath, if something's found, then treatment will begin at that time, or a decision about treatment may be made at that time. So cardiac catheterization is a very invasive type procedure. Basically, it is typically used for determining the location and extent of the disease process, assess stable or severe angina unresponsive to medical management, unstable angina, look at uncontrolled heart failure, ventricular dysrhythmias, cardiogenic shock. Really, it's used to determine the best therapeutic options for these patients, whether it's percutaneous transluminal coronary angioplasty, PTCA, stents, whether bypass is going to be better, whether we need to do a valvotomy versus a valve replacement when we're looking at valve damage. Or they may be used just to evaluate the effects of the medical and invasive treatments been done in the past. To look, are those coronary bypass grafts still open? Has the medication made a difference in these patients? Now, there are risks associated with this procedure, as any other type of procedure that basically you're going to be entering the body and going through the arterial system. Now, do understand there's two types of cardiac catheterization. There's a right-sided and a left-sided catheterization. The right-sided basically is just going to give us a look at the right side of the heart, and is not as prone to problems because you're going through the venous system. The left-sided heart catheter is going through the arterial system and has many more risk involved with it than the right-sided heart cath. So when we look at the risk associated with the catheterization, those should be explained by the cardiologist before the patient goes, and should be part of the permit that the patient signs before they go to this procedure. Now, the risks include myocardial infarction, because basically we can cause blockage in those coronary arteries and cause problems. Can have stroke, because if you're doing arthrectomy or you're doing angioplasty, part of that plaque could break off and cause problems. Thromboembolism can be a problem. You can get lethal dysrhythmias on these patients, which is a problem. Most of the time that's fairly easily treated. You can get dissection of the artery, basically from the area. Death is a big thing. Other things that you may see, these are some of the bigger ones. You can see bleeding, infection, and one of the big things is that, and we'll talk about part of the post-op care of these patients, is if you get the hematoma in the groin area, which is where it's typically done, you can actually get enough pressure that you're cutting off circulation to the extremity distal to that area, and can have necrosis of the tissue. That's why it's so important as part of your post-op care to make sure you're checking that side and checking those pedal pulses. Now the good thing is, basically, we're seeing more and more caths being done either through the brachial artery or through the radial artery. These patients tend to be able to get out of the hospital quicker. Tends to be less problems as we're moving along. Nursing care for these patients basically is going to be, for most of you, is going to be the pre and post-op care that goes along with these patients. And we're going to talk more specifically about that. Let's talk just a little bit about PTCA, percutaneous transluminal angioplasty. Remember when we talked about the different types of coronary artery disease, that basically what we're looking at most of the time is a plaque buildup in those areas. And if there's a plaque buildup, we can go in there and actually run the catheter up, find the area in the coronary artery, inflate a balloon, and then as that balloon inflates, it presses back this plaque. Okay, so that's basically a PTCA. Now, what can happen is basically several times that this plaque will actually just pop back out, and you basically have that coming back again. So it would be unsuccessful. What they've done to this just kind of shows it again, looking the balloon going in. It's uninflated, it goes in, then it inflates, and then basically it pushes it back out. So that's what a PTCA looks like. Now, one of the problems that we're having is these patients would reocclude fairly quickly. So what was designed is what's called a stent. Okay, a stent's basically a metal band that is placed in place. It's basically over the balloon here. The balloon goes in flat. Once the balloon is expanded, the stent then spreads out and expands, and then basically holds that plaque area back out of place. Now, these patients will need to be on some sort of platelet medication to prevent platelet aggregation, whether it be Plavix, whether it be aspirin, or a combination of both of those with these patients. There are two types of stents. There's what's called a bare metal stent. I'm sorry, I thought I had that, but I don't have that, it looks like. There are two types of stent. There's one that's called a bare metal stent. Bare meaning it's nothing but just metal. There's nothing coating, no coating. It's just a metal stent that's in that coronary artery. There's another stent that's called a drug-eluting stent. And basically, it is actually coated in a drug that will actually prevent aggregation of platelets in the area. So it's up to the physician what they want to do, is which type they want to use to do those type things. Again, this talks about up here, some stents are coated with a drug that slowly releases factors to inhibit aggregation of fibrin and clots with those patients. So again, that's going to be physician's choice when you look at that. An arthrectomy, I haven't seen many of these, taken care of many patients with these, but basically it takes place just like a coronary, like a catheterization, and everything goes through, and they basically go up, and the tubing goes up and goes to actually where the plaque is located. You can see here we have the plaque, and then this uses a rotary blade that actually basically breaks up that plaque and then actually vacuums it up and takes it back out. This one actually uses a diamond burr, and this one uses a different type of thing to do that. There are more risks with this because some of that plaque can break loose and move out of that system and move further down the system. Don't see that as much anymore, but it is something you may see. Again, the care of this arthrectomy, care of a PTCA, care of a cardiac cath patient are all going to be the same, and we're going to talk about that as we move along. Same thing when we talk about atrial fibrillation and we talk about patients who have EPS studies. That post-op care is going to be very similar because when they do the EPS studies, it goes in just like a cardiac catheterization type patient. So that care of that patient is going to be very similar to these type patients. So what is our responsibility as nurses getting these patients ready to go to a cardiac catheterization or a PCI, which includes all of the things that we have talked about? Well, of course, there has to be orders written, and then basically we will take care of what needs to be done with these patients. There is a skin prep that's done. No longer do we shave. And of course, most of you know that already. The skin is clipped of any hair, especially if it's in the groin area. If it's in the brachial area, it's also clipped from around those areas so that we don't have any hair in the way on these patients. Patient basically has to have a permit signed. Physician has to complete that, and then we as nurses will get that permit signed. Labs will need to be drawn. Labs need to be, depending on where you are. At Huntsville Hospital, the labs have to be within the last 48 hours. But typically what we're going to see is a CBC, complete metabolic panel, PT, PTT, a CPK with iso enzymes, which includes troponin. We're probably going to see, those are the major ones. A lot of times you'll see a fasting lipid profile done on these patients. But you especially need that PTT, the CBC, the PTT, and the chemistry profile to make sure everything's going okay. When you're looking at that chemistry profile, pay special attention to the BUN and creatinine and the potassium levels on these patients. All of these tests use a radiopaque dye, which can be damaging to the kidneys. So it's very important that we take a look at those, and always those will need to be reviewed prior to the patient going in the morning, going to the cath lab. Medications, most of the medications are actually going to be given to these patients prior to them going to the cath lab. At Huntsville Hospital, the only drug they really hold are metformin. Metformin needs to be held 24 hours prior to the test if possible, and 48 hours afterwards. Other drug that's going to be held would be like Lovenox, Pradaxa, Xarelto. All of those need to be held prior to the exam. Typically, most of the medications the patients are going to be given ahead of time to be given. They are given that usually at 6 o'clock in the morning with a sip of water, their routine medications. One of the things that if a patient has a prior history of kidney disease or kidney disorders, sometimes these patients will be admitted early, and we'll begin hydration on them. We'll go ahead and start an IV and start getting them IV fluids. We'll also give them a medication called Mucomist, acetylcysteine. Mucomist basically is really a drug that was used earlier on for nebulizer treatments to break up the mucus and everything in patients who are having trouble breathing. Mucomist has been found to have a protective effect on the kidneys from these dye-type problems. So you may see patients being given Mucomist prior to and for 48 hours after a PCI just to help protect those kidneys. Again, you're going to be monitoring the BUN and creatinine on these patients while you're doing that. If that patient happens to have an allergy to some of their allergy to iodine, betadine, contrast medias, of course you need to notify the physician about those type things. Standing orders at Huntsville are basically to give them Benadryl 25 milligrams when they come in for the cath, and then give them 25 milligrams every 8 hours times 2 after that. They'll also get Solumedrol 125 at the time of admission, and then every 8 hours after that. And we'll get Tagamet, cimetidine, 400 milligrams at time of admission, and every 8 hours times 2 doses. All these patients should be getting an aspirin, 325 milligrams prior to the procedure, before they go for that procedure those days. Again, we want to make sure that we identify the allergies on these patients. They have allergy bands on. We have looked at the labs. We have them clipped, and we have them permitted before they go. At Huntsville, basically, an IV is started on the patients at 4 a.m. in the morning prior to the day of the catheterization. It started at 125 an hour. Unless they have a history of congestive heart failure, then it's only at 30 milliliters an hour. Or if they're on dialysis, then it's only at 30 milliliters an hour. If They are, of course, these patients are going to be NPO until the catheterization, usually after midnight before the day of the catheterization. These patients will also, if they don't go by 10 o'clock, the IV fluids are usually cut back to, I think it's 75 milliliters an hour on these patients until they go for their catheterization. Other thing that when I say here ID pulses, part of the things that we're going to be doing is actually checking the pulses on these patients once they return. So it's real easy before they go for that procedure. If you know they're going to have one in the groin, then you need to go ahead and locate that pedal pulse, document whether it's 1 plus 2 plus 3 plus 4 plus, and then mark it with a marker so that it's real easy for you to find when they come back from the procedure. Now, if they're having a brachial, you'll need to find the radial artery so that you can be checking pulses distal. Now, if they have a radial one, you'll just be checking circulation distal to that, capillary refills, those things on these patients. Typically having good results with the arterial sticks on these patients. So those are some of the pre-op type things. Now, post-op, once that patient comes back to you from the cath lab, they're basically to be in bed, head of the bed no higher than 30 degrees. Some physicians want them flat, but majority are now letting them have that head of the bed up 30 degrees. If it's a femoral stick, that leg needs to stay straight for 6 hours, and the patient will stay in bed for up to 6 hours. Now, many times what we'll do is we'll take a sheet, put it over that leg, and just tuck it under the mattress. Not restraining them, but just a gentle reminder not to move that leg for them. Vital signs are every 15 minutes times 4, then every 30 minutes times 2, and then basically every hour times 4. You also, during that time frame, you're going to be checking the dressing, looking for any bleedings, any signs of hematoma, and you're also going to be checking that pedal pulse and make sure there's not any changes in the pedal pulse. Again, we talked about one of the complications is that hematoma. If that hematoma develops, it can put pressure on the artery and also on the vein and cause problems for the patient. So it is your responsibility as the nurse to make sure that you are taking care of that patient. You're doing the vital signs and you're documenting those issues as well. So make sure you're not just checking the dressing. Check the patient. Check under the patient, because if they're bleeding, it could be oozing out behind the dressing and going onto the bed. So don't just barely pull the covers back. Look at the dressing and see what's going on. If the patient does develop a hematoma and you notice they're bleeding, put direct pressure on that area. Have someone call the cath lab for the physician that performed the cath on this patient. Many times they're going to be taken back over to the cath lab and checked out for those type of things. Post-op, again, we're going to hold that positioning we talked about. Medications, they should resume most of their medications. Many times they're going to be put on new medications. Again, that's up to the doctor. Really remember that the metformin has to be held for 48 hours after these kinds of things. Patient can resume basically a regular diet once they have been recovered and are feeling okay. Now, post-op, we also need to do teaching with these patients. Typically, we want these patients to limit their activity for at least a week, maybe longer depending on how they're doing. Definitely avoid any heavy lifting. We want them to leave that dressing intact for the first 24 hours, and then they can take it off. Teach them about watching for signs and symptoms of infections in those areas. These patients, most of the time, are going to do very well. Sometimes, again, we'll get a hematoma, but that's usually the worst part, and we'll take those patients back to the cath lab and express that hematoma. This is just a look at some of the post-coronary catheterization orders from Huntsville Hospital. You can kind of take a look at that again. Talked about typically the doctors, some will say supine. I will want them in a supine position. You can elevate the head of the bed 30 degrees. Closure devices are different types of devices that physicians use to kind of help prevent the bleeding. Some will not use a closure device. Some will use just direct pressure to the area. Down here, discontinue heparin, restart 6 hours after the sheath's removed. If they vagal down, can give atropine for that and bolus of normal saline over 15 minutes. Talked about holding the glucophage or any medications that contain glucophage of those type patients. If you see an aneurysm, got to initiate cardiac for treatment of pseudoaneurysm, notify the individual physicians. If a radial cath is performed, there's special orders for that radial cath, and I'll get you a copy of those and put them up on the website here so you can see those as well. So when we start looking at these patients and we start talking about what kind of problems we're talking about with our patients who are being admitted for this coronary artery disease and these type issues, here's some of the nursing diagnoses that you may see. Acute pain related to tissue ischemia, activity intolerance related to imbalance between myocardial oxygen supply and demand, anxiety related to the whole process or maybe going for a procedure, new medications, whatever, risk for decrease in cardiac output, ineffective tissue perfusion, knowledge deficit on the whole process, medications, whatever, fluid volume overload if we're getting into some of the congestive heart players, and there's always risk for injury with these patients. Our nursing priorities basically are to relieve the pain and anxiety. We want to reduce that myocardial workload, prevent, detect, and assist in the treatment of life-threatening dysrhythmias, and promote cardiac health and self-esteem in these patients. One of the biggest things there is to promote that cardiac health. Again, we talked about all of the problems that we have in this nation with us being overweight, hyperlipidemia, tobacco use, those things. Promotion of a healthy lifestyle is very important, and that's something you're going to see pushed more and more as you move forward. I hope you've enjoyed this series of lectures on coronary artery disease. Good luck. Thank you.